if you look at a book, if you've ever had to read up on PAD, these are the classic classification systems, but we're actually not using them as much as we used to. There's a book called the Rutherford Textbook of Vascular Surgery. It's the most famous book, and every fellow has this book. And this is his classification system he invented decades ago, as you can see here. But there's a new classification system put out by the Society of Vascular Surgery called the Wi-Fi system. And it has, even though it has 4 letters, it has 3 components. And here's the components in a table format which is impossible to memorize. No one knows this table. But I just want you to remember there's 3 components to losing a leg. One is ischemia, right here. The more severe the ischemia, the more likely you're going to lose your leg. The second component is the wound itself. Does the wound look small and simple, or does the wound look severe and large and big and deep? So the more severe the wound, the more likely you're going to lose the leg. And then the last component of the Wi-Fi classification system is infection. So the more infection, cellulitis, complex multibacterial infection, the more likely you're going to lose the leg. So all 3 components, infection, the wound, and the ischemia, play a role in whether you can save the leg or lose the leg. And that's the future of the PAD classification. We use this term CLI, critical limb ischemia, all the time. They're trying to change that because, again, we're not trying to use this Rutherford classification system anymore. So they're trying to change it to this new term, critical limb threatening ischemia, and they're going to eventually incorporate other aspects. 1, the Wi-Fi classification system that I just mentioned, and 2, angiosomal theory, which is, it's not just the fact that if they have blood flow to the bottom of the foot, they should be fine, but if they have blood flow to the bottom of the foot, but the wound is on the top, they're not fine. So this is an evolving issue, but it's something that will happen in the next several years. So that's not the focus of this talk. The focus of this talk is treatment. And when I think of treatment for PAD, there's 2 things. 1, for PAD, the most common symptom of PAD is trouble walking. So what are the treatments that help a patient walk? And then 2, as I mentioned, the sequelae of having PAD is systemic. So what are the treatments that can reduce those systemic effects? Heart attack, stroke, death, losing your leg. So those are how I conceptualize the treatments for all my PAD patients. How do you walk more with less pain, and how do I prevent you from dying? So step 1, always step 1, is smoking cessation. I'm not going to quote any studies because there's more than I can think of that says how bad smoking is, how direct a relationship, causal relationship between smoking and PAD, smoking and amputation, smoking and death. So there's a number of ways I counsel the patient on how to quit smoking, and I've listed just a few of them here. Nicotine patches are the most common. Nicotine gum is probably second, but also the least effective. I've not had very many patients who succeed with nicotine gum. It also costs a lot for most patients with most insurance plans. I've had some success with a lot of patients with the pill. And there's 2 pills, Chantix, which somehow got recalled. Those of you that try and do smoking cessation, for some reason the manufacturer of Chantix had a problem with their distribution or the ingredients, and it's recalled. So now we're stuck with Zyban or Wellbutrin. Now there is an issue with getting this covered with some patients. So if a patient has depression, I'll prescribe it as Wellbutrin instead of Zyban. So anyway, the other issues are ways you can get patients to quit smoking. There's group therapy at the VA hospital where I also practice on call. There's group therapy. And then lastly, you may not believe this, but acupuncture and hypnosis works too. And I don't know if every hospital or private practice group has this available, but at Loyola, several of our family practice doctors listed here all practice acupuncture and hypnosis. And I've actually had several patients quit smoking with hypnosis, believe it or not. Smoking is so effective and the evidence is so strong that the government will pay you money to convince your patients to quit smoking. Here are the CPT codes that you can bill to get reimbursed for just talking with your patient about smoking cessation. And then here's the RVU. So it's not a lot. I listed here if you were a clinic and you're billing a level 3, level 4 encounter, these are the RVUs you're getting. You're going to get a half RVU or a quarter half RVU for talking about smoking, but it's something. It's something. So it's so important that the government is willing to pay you to tell your patient to quit. The second thing, and you notice this again, is not a medicine. The second most important thing to getting a patient to walk more and have less pain is exercise. Exercise is good for everything. It's good for the heart, it's good for the lungs, and it's actually directly good for PAD. There have been several studies that show that exercise therapy is almost as good as balloon angioplasty. It increases walking distance, but there are specific caveats. One, you can't just tell a patient to walk. You have to tell them exactly how they need to walk. And here's the criteria here. 30 minutes or more, 3 times a week or more, 3 months or more. And how does that work? Why does walking, telling a patient who's already having trouble walking, help them walk further? Well, if you walk to the point of pain, your body's going to tell you there's something wrong. And your body's going to try and fix it. And one of the ways the body tries to fix it is they release stem cells and vascular or neogenesis. So then they're going to try and grow new blood vessels to help resolve the pain. That's your body's natural defense self-mechanism. And exercise therapy helps do that. Unfortunately, just telling your patient, again, is not good enough. Sometimes even telling this criteria is not good enough. So studies have shown that if you do supervised exercise therapy, you have a nurse, you have a physical therapist that actually watches your patient do the walking program, you'll have more success. So much so that the government started reimbursing for supervised exercise therapy. Again, you know if the government's actually paying for it, it really is doing something. So in 2017, CMS, Centers of Medicare, Medicaid, started paying whoever wants to do the supervised exercise therapy. So it has to be a qualified health professional, like a physical therapist, and they can supervise the exercise training program for up to 36 sessions. I mean, that's a lot of sessions that the government is willing to pay for to get you to walk and have less pain. And why is the government doing that? Because it's helpful in all those scenarios: heart attack, stroke, death, and preventing you from losing your brain. There is a medicine to help you walk more, and that medicine is silastazole. We used to prescribe this other medicine, pentoxifylline. I used to describe it to my patients as it makes the blood vessels more squishy. It doesn't actually work. When they did a randomized controlled trial of pentoxifylline versus silastazole or Plato, pentoxifylline, although it quote unquote had an increase in walking distance, it wasn't different than placebo. Whereas silastazole does. Now here's the problem. If you have a patient who walks 50 feet claudication, and I give them silastazole, now they can walk 70 feet, they're probably not going to be happy. That's probably not enough. It's something, but it's not going to be enough, but it's something. However, if you have a patient, and I have plenty of these who are older, healthier, for some reason they play tennis and golf a lot, and they can walk a quarter mile, and you tell them you give this medicine and now they can walk almost a half mile, those are happy patients. So it's a good medicine. The only issue is phosphodiesterase inhibitors like silastazole have been noted to increase mortality in CHF. So it's a black box. Even though it's never been shown with silastazole, if you have CHF, you shouldn't give silastazole. So in CHF patients, I give pentoxifylline. That's the only reason it's still on the market. Here's a new one, and we just discussed this at our local journal club. So we always talk about diet. Patients ask me, well, what can I eat to help me walk better? And I say, well, you gotta eat healthy. Vegetables, low fat. But one of the interesting things is actually eating chocolate. So studies have shown that dark chocolate, now this isn't Milky Way bars. This is bitter dark chocolate. So bitter dark chocolate increases mitochondrial activity. And the mitochondrial activity, for those of us that remember biology from a long, long time ago, that's responsible for cell energy production. So by taking cocoa, you increase the walking distance 40 meters immediately after, and 20 meters one day after eating cocoa. So if you can convince your patients to start eating really dark chocolate every day, maybe, so I bet this will be the future. we're going to have more studies looking at diet changes to improve walking distance in PAD. So it's good to increase the walking distance, but ultimately the most important is to reduce all the serious events: cardiac, stroke, limb. So there's a bunch of different medicines, and this is the most common thing we do as physicians and other providers. And there's a bunch of new medicines on the market that I'm just going to briefly touch on and whether they're actually useful or not. So the first are antiplatelets, and the one that everyone knows about is aspirin. The second one that almost everyone knows about is Plavix, but there's two other newer ones that were released in 2009 and 2011. And for those of you that don't remember this from school a long time ago, this is the clotting cascade that I don't expect anyone to remember. But just to show you what these do, so all of these newer agents, Plavix, Efient, and Brilinta, they all inhibit this funny protein right here, ADP. And that ultimately prevents platelet aggregation and ultimately prevents blood clots. So that's just the overall, what they do generally.